Good afternoon, everybody, and thanks very much for joining. So a warm welcome to the Scale Neonatology virtual Grand Round with West Yorkshire, LMNS and Uganda. So this is our seventh meeting, and it supports the Scale programme in developing links between Uganda and the UK in terms of neonatology. We have created a list of topics which we've done through working together with Uganda and West Yorkshire to decide which themes actually had some really good opportunities for shared learning. Everybody should have had a Zoom teaching meeting questionnaire to fill in, and at the end there will be a post-meeting evaluation, and we'd be really pleased if you could fill that in, because that gives us some really good ideas of future topics going forward and how we can improve. The title for this one is The Role of Immediate Kangaroo Care in Thermoregulation and Survival. And I'm delighted to welcome the team from Pinderfields, which is a big level 2 hospital in West Yorkshire. And Sara, Didier, is one of the consultant paediatricians, and she's got a team with her who are hopefully going to present first, or maybe not. And then we're going to follow on by the team from Mbale. So Sara really is going to talk about sort of setting the scene about why kangaroo care is important, and also trying to move KMC forward into different settings in terms of the delivery suite. So without further ado, a very warm welcome to Dr. Sara Didier, and I'll hand over to you, Sara, for the first talk. Thank you very much.
Kath, thank you very much. We had hoped that this would be a joint presentation between myself, one of our NMPs who's actually facilitated of 1 or 2 delivery room cuddles on our unit, and one of our FI care nurses to make this fully representative. But unfortunately, one of our nurse, Christina, who was going to help, was on nights last night, having to do an extra shift, and Becky is, I think, probably over in labor ward now, expecting a delivery. So I'll make a start. You are there, are you?
I am, yeah.
Oh, great.
I'm here, don't worry.
Okay, well, okay, so we'll be halfway there to what we'd planned. So yes, can I have the first slide then, please, Jeanette? So we're going to talk today about the role of immediate kangaroo care in thermoregulation and survival. Next slide, please. So the aims of this presentation this afternoon are to discuss the origins of kangaroo care, review a protocol for immediate kangaroo care in the delivery room, and then discuss the experience of some of our own parents on the unit about how they felt having to do kangaroo care with their babies. Next slide, please. So why this topic? Well, I think this group of people will know for certain that preterm birth represents one of the major contributors to the leading causes of death in children under 5, accounting for nearly 50% of the deaths. And then in England last year, the data that we collect from March 2022 to 23, that's National Child Mortality Death data, reported that prematurity was a cause of death in up to 34% of babies. Next slide, please. Well, infants under a year, I should say. Complications are often due to the complications of prematurity, which include infection, respiratory illness, and poor temperature regulation. But in fact, even without intensive care, many of these deaths can very likely be avoided with good kangaroo mother care, because it has been shown to be an intervention that has significantly reduced mortality in infants worldwide. It does this by reducing hypothermia, reducing the incidence of hospital-acquired infection, improves growth because early breastfeeding is involved. It promotes brain development and reduces hospital stay, leading to early discharge. But unfortunately, even with these very good characteristics, kangaroo mother care is not actually universally practiced to a very high level. Next slide, please. So what actually is kangaroo mother care? Just reading the literature, I actually had no idea there were so many different variations in the definition, but the original definition of KMC required 3 essential components. And these are early but continuous prolonged skin-to-skin contact between mum and their preterm baby, exclusive breastfeeding or at least breast milk feeding, and early discharge with follow-up at home. And this was careful, routine follow-up performed. But still, today, skin-to-skin contact or kangaroo care, those terms seem to be used interchangeably, and they can mean anything from an infant being cared with skin-to-skin for any period of time, not necessarily prolonged hours of time. And it also is sometimes used to refer to simply a mum caring for her baby when the infant is actually clothed and on her chest. There's a new term that I also found in doing the preparation for this, which is sort of an IKMC, which stands for immediate kangaroo mother care. And this tends to refer to kangaroo mother care occurring immediately after delivery, involving zero separation. So sort of like our delivery room cuddle. Next slide, please. So where did it all start? Well, actually, the origins of kangaroo care seem to be linked to Dr. Sanabria, who was a Colombian pediatrician who noticed who was sort of battling with increased, very high mortality rates in his region because of overcrowding and lack of resources. And he took preterm, otherwise relatively healthy babies and introduced this concept of continuous kangaroo care, getting mums breastfeeding and teaching them to breastfeed while they were having kangaroo care, and noticed that there was a dramatic fall in death, and babies were being able to be discharged sooner with fewer complications. Next slide, please. And this is actually quite a good article. It's from a team in which was involved, maybe some of you are aware of this study. It involved 5 university hospitals in moderate resource countries and poor countries. So that was Ghana, India, Malawi, Nigeria, and Tanzania. And it was sort of led by a team in University of Norway and the Karolinska Institute in Sweden. And what they did is they looked at over 3,000 babies with a birth weight between 1 kilo and 1.8 kilos, and they randomized them to two groups. The intervention group was looking at giving immediate kangaroo care, and that was going to be up to 17 hours of kangaroo care with exclusive breastfeeding, and a control group, which was looking at sort of conventional incubator care or radiant warmer until the baby was stable, and then they were going to have kangaroo care after stabilization. In the intervention group, mother and baby received medical care in the same unit. As I said, there was breast milk feeding. In the control group, what they did is the mum and baby were separated in different units, and they were only reunited for feeding. And on average, the time that in the control group that mother and baby were together having skin to skin was about 1.5 hours. The primary outcome was death in the neonatal period and in the first 72 hours of life. So prior to the study, when they matched the two groups, they found no differences between the two groups, and they ensured that training in basic neonatal care, any ventilation that was required, and also the management of babies who might have been unstable in skin to skin was managed by the master team in Sweden and Norway. Next slide, please. And what they found in the first 28 days of neonatal death was 12% in the intervention group, and in the control group that was 15.7%, with a relative risk of death of 0.75 and 95% confidence interval and a p-value of 0.01. In the neonatal and in the first 72 hours of life, neonatal death in the intervention group was 74 infants and 92, so about 5.8% in that group. Actually, the trial ended up being stopped early on ethical grounds because they found such a improvement in the mortality rate in the intervention group. Next slide, please. So what I've done is going to show you the next two pictures kind of just summarize the multiple benefits that have been linked to kangaroo care from various studies over the years. So next slide, please. And I've divided them into sort of benefits to the baby and benefits to mum. So slightly out of your screen, but if we go from left to right on your screen, it's been linked to, so kangaroo care has been linked to better milk production. Mums and babies are together for that length of time. They also appear to breastfeed for longer, and we know the benefits of that. And ultimately that leads to better neurodevelopment outcomes. There's a stabilization of autonomic function, temperature, breathing rate, cardiovascular status, and ultimately that can be linked to improving developmental outcome. There's been some studies as well looking at babies who've had prolonged kangaroo mother care at 3 and 6 months compared to a control group, and looking at how these babies respond to stimuli. They seem to have a better sleep-wake pattern. They seem less irritable. Then, of course, we know about so much work now being done about the infant microbiome and how that relates to long-term health, immunity, relationship with infection and breast milk. And finally, about the reduction of distress and improved bonding between baby and mum. Next slide, please. And looking at it from the parental side, lots of information about improving parental attachment and feelings of well-being, being able to bond with their baby, ultimately leading to better mood in families, which will, and between mother and baby, which will ultimately lead to better care, better milk production. Next slide, please. And there are wider benefits as well. I think that kangaroo mother care puts parents at the center of their baby's care, and that's something that we should be doing, making sure that parents are partners in the care of their baby. Certainly in the UK, this is something that is considered to be one of the things that we should be aiming for on our unit. There's a very strong evidence base for kangaroo mother care, and as clinicians, we really want to be using good evidence when we have it for better outcome. There was an article in Paediatrics Journal in 2016 which sort of tried to quantify the risk of infection and growth in two groups, again similarly matched, having kangaroo care and having standard care, and they found both improved growth, increased length of time of exclusive breastfeeding, and reduction in infection. And then again, I've just chosen this other article from Developmental Psychology Journal by Feldman and colleagues, which looked at, again, matched infants for weight and medical problems and family demographic. And they looked at infants. This is one I alluded to earlier, at term, at 3 months and at 6 months, and found that the intervention groups, so the babies who had received longer kangaroo mother care, had this better sleep wave cycling by 3 months, and by 6 months had better interactions, and their development was on track for 6 months. And of course, allowing early discharges is going to be cost effective. Next slide, please. So if we look at what the actual definition of KMC, there's you want to counsel the parents of what this is going to entail, because there's going to be a prolonged period of time. Babies should really be just in a nappy with a hat. They're placed upright onto mum's chest, so that their skin, they're going to be directly in touch with mum's chest, with their head turned to one side, hips flexed and abducted, and their arm flexed as well, and their head turned to one side. So their abdomen should be in line with mum's sort of general epigastric region. And in that position, mums can be taught how to, one, first express, and then when babies are able to continue to feed in that position. And I certainly saw some video in preparation for this, where in some of the Asian Pacific countries, mums and dads were doing phototherapy and having other treatments done, all while having kangaroo care. So I'll hand over to Becky, if you're still there, Becky, to take us through how to implement an example of how to implement delivery room cuddles for our preterm infants.
Good afternoon, everybody. My name's Becky Walker, and I'm one of the advanced neonatal nurse practitioners here at Pinderfields Hospital. I was asked just to speak briefly today by Sara about delivery room cuddles for all preterm babies, really, if we can facilitate this as a more regular thing, because currently this is more done on an ad hoc basis, depending on condition of infant or who is attendance at delivery, etc. So we've heard from Sara the widespread benefits of kangaroo care for babies after delivery. So what can this mean for parents and families straight after birth, really? Got the next slide. Traditionally, we often felt that there was a quick need to whisk our preterm babies away from their parents, and with quick stabilisation at delivery, with gung-ho for intubation, and moving babies straight away with this predominantly traditional showing of the baby, perhaps more so to dad on a resuscitaire and not to mum, who may be still in theatre or on the delivery suite bed. So in traditional neonatal care, where we admit babies with the focus of being that we work in partnership with our families, it appeared that we've lost the sight of this in the delivery room, taking control, rather allowing that parents that moment soon after birth. So now we know where our practices have changed and moved forward. So we're not in the quickly whisk away. We're allowing babies to transition. We're using more gentler forms of ventilation. So probably maybe just offering some facial PEEP and allowing for the delayed cord clamping. We feel that why should we now not make time to implement this into our practice? Got the next slide. So why implement this in practice? So through reading of the literature, it's become evident that during this cuddle or any cuddles with mum and dad, parental stress becomes reduced, feelings of parental competence increase, and the rate of successful lactation and breastfeeding is improved. Studies report that visual and physical contact with their newborn in the delivery room can help reduce feelings of trauma and separation for the mum and the family, and have a positive impact on maternal mental health. And it's also, as previously demonstrated by Sara, we know that infants in skin to skin have demonstrated enhanced physiological stability. So again, given these widespread benefits, why are we missing this opportunity with the urgency to remove the baby straight away to the neonatal unit? Given these optimal health outcomes will be more achievable if parents play an active role in supporting their preterm baby right from birth. So I saw this quote in an article and I just thought it was beautiful. So it says, the delivery room cuddle can provide a brief moment of calm that can be enjoyed by both in anticipation of the potential storms that might lay ahead for a family. So often waiting until the neonatal unit for parents to receive that first cuddle can delay that early maternal contact. We may have whisked that baby away. It may have been laid under drapes for a couple of hours while we stabilise, insert lines, take x-rays. So rather than that, why don't we help to facilitate this first cuddle before it becomes logistically more challenging once the baby is admitted to the neonatal unit and is then in an incubator, and then removing the baby to be placed into skin-to-skin contact becomes logistically more difficult, with wires and tubes and posing more physical barriers.
It's David Gibson here. I'm one of the consultants. I was not sure whether I could make it onto the meeting, but I was going to interject if possible at this point. And it was an example that Sara and myself discussed, that actually at the most extreme end of prematurity, this has been possible in Leeds. I think Kath may well be involved with this case of a 23-weeker was there, been intubated, ventilated, stabilised, and received labour ward. It was in theatre cuddles. This was a mum who had presented to us in threatened extreme preterm labour, risk of delivery at 22 weeks plus. She spent a number of days with us and decided, I'm going to wait till 23 weeks before I'll go for active management rather than comfort care. If I deliver before that, I think I'll let nature take its course. She met us at 22 weeks plus 5, having met every day, and said, I think for the sake of a day or two, I'd like to go to Leeds now. And we facilitated her transfer there. We discovered about a week later that baby had delivered at 23 weeks plus 0 and had survived for 7 or 8 days only. But the mum gave us a ring back to the labour ward, to neonates, and said, listen, you as a team and Leeds as a team did everything we could to give baby a best chance. And actually, one of the things she said, I had delivery ward cuddles with my baby, and I had that precious time to spend with my baby, even though they were at the extremes of prematurity. I'll be quiet now. Sorry, Becky. Go ahead. Yeah.
Thanks, Dave. We'll hand back over to Becky. Thanks for that. We'll just pull the slides back up.
So obviously we're making this process sound easy, but obviously it's not always an easy. So obviously communication is key. So obviously it's be something now we would bring into the counselling of parents. So when we visit our preterm ladies on delivery suite, if delivery is becoming imminent, we would discuss something that facilitating the delivery room cuddle, what that involves, what happens, for parents to have phones and cameras and things ready for this moment of anticipation. And also in theatre and things like that, obviously we're going to have to communicate between the anaesthetic team, making sure that mum is obviously going to be in a stable condition to receive the baby. So it's just working together to make sure that this is a smooth process rather than something that becomes quite stressful. I think we're ready to move on. Yeah. So the delivery room cuddle, what does that, what does it mean? What does it involve? So it's mum or dad or both being able to hold their baby prior to transfer to the neonatal unit. So often that means mum to have baby in skin to skin in a plastic bag if baby's extreme prematurity and has been supported by through thermoregulation support in the plastic bag. Obviously, babies to be stable before we start this process. So intubated if intubation is required, surfactant administered that the tube is nice and secure. So we're not going to run the risk of slipping or moving our tube when we transfer baby across. So this might even mean myself or the nurse, as we coordinate this, shifting across and sitting next to mum on the bed so we can do PEEP or bag and mask T-piece ventilation while the mum's got baby in skin to skin. The baby should be placed near mum's face if possible, and she should be encouraged to both parents to touch and touch their baby, kiss their baby if they so wish. So not losing the sight of the fact that it's their baby at the end of the day. And I always say to parents, this is your baby, and we're just going to be caring them for and helping to look after them for a little while, but essentially this is your baby. So allowing them that time. Obviously, if something changes during the time, so if baby becomes unstable or we're worried, then obviously the cuddle might be abandoned, and we would move then back to the neonatal unit. So I think the next slide, maybe, yeah. So I looked at some work. So we always say, why rewrite something that's been done beautifully already? So this was an SOP or a model that was introduced by the Great Western Hospital, who have produced a lovely flow chart about what to consider during the cuddle, the roles that we need to allocate, and just making things so that everything's ticked off and done, so everyone sticks to the same routine, really. So again, we've discussed it previously. So identifying a plan. Is everyone aware that the cuddle is going to happen, and that parents know that this may be abandoned if the baby's condition changes or we become concerned? Has everyone got a role? Who's doing what? Who's responsible for the airway? Who's moving the equipment? Who's helping to lift the baby? Have we communicated this as a team? Is everybody aware of what's going to happen? And obviously we've discussed the risks. So the risks to baby are possible accidental extubation. If the tubes become dislodged, we could be concerned if the baby's got becomes cold. Any mechanical failures, so resuscitator gas is not turned on, etc., or the rundown, and the concerns of like the length of time, what's appropriate. We don't want our baby to then be admitted to the neonatal unit in a poorer condition to what would have been if we'd have just whisked them away as tradition. And thinking about the other impacts, if we're getting a colder baby, are we then going to have a hypoglycemic baby on admission and run into problems that way? So I think the next slide might be the lovely flow chart, which it looks tiny on my screen, but I'm not sure if you guys can read it.
It looks tiny on the big screen.
It is quite small, but maybe we could send that round after the after the meeting that everyone could see, because it's a really helpful flow chart for everybody. So we could do that afterwards. So we'll let you talk through it, but we'll sort it out. Yeah, so it just, like I say, it's I can't take credit for it. It's the work of others, but it just provides a method, a step-by-step approach to making sure that everybody's aware that the baby's transferred safely, so we don't run into any problems. So it would be making sure equipment's ready, that there's a plastic bag available, that we've thought about thermoregulation support, that we've checked the usual, the gases, the TPs, the mask sizes, things like that, everything that you would do essentially when you're waiting to receive a preterm baby. Once stable on the resuscitator, we've gone through our things. So babies receive delayed cord clamping if that's appropriate. We've stabilised that baby to transition to ex utero life, if that's been with face mask ventilation or intubation if required. And if baby is intubated, that we've got a stable patent airway and the tube's nice and secure. We know our babies just after delivery are nice and wet and slippery, and stickers don't often stick to faces, and tubes can slip and dislodge really quite easily without the fault of anyone, really. It's just it could be one of those things. So once we're happy with baby, we can check the temperature just prior to going onto mum's chest, so we know that we've got the baby in optimum condition before we transfer baby. So we check that baby's nice and warm. And then we move to prepare the baby. So everyone's got their assigned role. We've discussed it. And then depending on where you were, theatre or in a delivery room or triage or wherever these babies can be born, moving the equipment nearest to baby so we're not pulling or dragging on any of our tubing, things like that. That mum's ready, and there's nothing for like trip hazards or anything like that. You don't want to be the one transferring the baby. Mum's epidural or drip stands behind your foot, and it just takes one little trip or fall for something disastrous to happen. So once everybody's ready, everything's checked, someone's supporting the tubing if they need to, baby's moved onto mum's chest.
Like I say, that might mean you as the nurse or practitioner shimmying across and sitting on the side of mum's bed so you can do the bag of mass ventilation or oxygenation. Again, same as kangaroo care, that baby's placed in skin to skin on mum's chest with baby's head near to her face, so she can see, touch, smell her baby. We've had requests of very recently, and taking all those feelings and that rush of emotions that any new mother should feel when they're holding their baby for the first time. Also, it would always be dependent on stability of the baby. Is it appropriate for them to transfer baby onto dad's chest if he so wishes? Have photographs been taken, video recordings, things like that. So there's been reports of these cuddles lasting from anything from 30 seconds to 30 minutes, depending on the stability of the baby and if the baby's managing to maintain the temperature and everybody's happy. So it's dependent. There's no written rule for how long this can happen. I think the most important thing to take away is that it does happen. And then once ready, again, we communicate moving back babies safely back onto the resuscitator and transferring them back to the neonatal unit. This is an image I just found on the Google of a baby, obviously quite preterm, in their little plastic bag, intubated and ventilated, having their delivery room cuddle with mum. So, oh, sorry. So again, the message was, why aren't we doing this? Is there or should there be no excuses why we're doing this? So if the evidence is clear, why we're not making it more of our common practice when we attend our preterm deliveries? Babies, oh, sorry. I know, I apologise if I'm talking a little fast. I do so when I'm nervous. So if parents have had that opportunity and they've had that contact with their baby prior to admission to the neonatal unit, we mentioned previously, those parents can often be separated for the next few hours if we're stabilising babies with lines and tubes, etc. It's not uncommon within our region for babies who need higher levels of intensive care or born quite preterm would need to be transferred out of region to another hospital. And again, there'll be longer periods where that mum and baby could be together and have that physical contact once again. And parents report that the fact that they'd had that opportunity for bonding really helped that initial anxiety around that separation. Again, David said we've also had the feedback of parents who have had a baby that have had that delivery room cuddle, but subsequently, unfortunately, baby has passed away. That was the only opportunity that they had to hold their baby while they were alive. And the second time was at withdrawal of care. So, yeah, no excuses. So how can we move this forward? Why and how can we make this a standardised practice for our delivery room support and of our preterm babies? So again, it means working together as a team. That's just not our team, that's with the maternity services again. So we can embed this more into our common practice rather than it just becoming an ad hoc thing. Obviously, we need the whole team to be on board. And obviously, if training or education was an issue, we've got ideas to do some Sims training with the dolls and things like that, what the practicalities are of moving a small baby from the resuscitator in theatre or in a delivery room that might be crowded with equipment and people, lots of people, and just been a champion of it, really. So everyone can be on board and realise how important this snapshot in time could be for a parent who's about to embark on a quite treacherous journey. Thank you. I'll hand back to Sara if she's still there, because this is her little work that she's done with two of our lovely mummies who are on the neonatal unit at the minute.
Thanks, Becky and Dave. I'll hand back over to Sara. Do you need the slides sharing again, Sara? Yeah.
Yes, just to, if you kindly, we've got 2 6-minute clips or so from 2 mums who gave me their feelings about being able to do kangaroo care on the unit. I had 2 clips from 2 mums. One mum who sadly had rupture of membranes at 10 weeks. She went on to threaten preterm labor at 26 weeks. She presented to our level 2 unit. She then got transferred to Leeds, and as you can imagine, she had an extremely rocky course. Her experience of kangaroo care is probably one of the most moving I think I've ever heard. She was given her baby, and in her words, to die, because the team had felt that they were at the point of reorienting care. And she and her partner, everything had been turned off, all of her drugs had been turned off, and the baby was just on the ventilator, and they were allowed some skin to skin. And oh God, I'm so upset that you can't hear what she said, because it was just so moving. And they had that time, and she described it as being both the best and the worst time, because the best time, she's having skin to skin with her baby, and the worst, but she said, in her words, you know, she was given these babies because they were about to die. And an hour later, she was still having skin to skin, and the team were thinking, oh dear, what's happening here? And essentially they went back to active care of this baby. And that was when she was born at 26 plus 3. She's now 36 plus 4, putting on weight well, and you know, we're getting her ready for home. So that was one of the first ones. Now we'll get Lauren's feedback. Lauren is the wonderful mum of Mila, who was born at 26 plus 3 weeks, and is with us here doing very, very well. So I'd like to ask you about your journey and how you think that having skin to skin with Mila has helped you.
So we had skin to skin with Mila when she was very, very poorly. We were saying bye to her, essentially. And the skin to skin, we think, is the only thing that could have saved her, essentially, because everything was switched off apart from a ventilator. So it's very important. It's like the most important thing in the world.
Yeah. And your journey, if you don't mind sharing, when you presented at 26 plus 3, a few things had happened before that time, hadn't it?
Yeah. My waters had gone at 10 weeks, so we were sort of living on a knife edge with the pregnancy anyway. It was very hit and miss as to whether she was going to survive in the womb, let alone out of the womb. So, yeah, it was a rough ride.
And how did you feel that first time then, when take us through how you felt?
It was heartbreaking, because we were saying bye to her. That was the reason why we were having the skin to skin contact. But then in the same breath, she was pink, she was alert, like her eyes were open, she was looking at us. Obviously she couldn't see us, she was very, very small. But it felt amazing. It was a big mixture of emotions. Because it was horrible, but incredible. And then the fact that she was okay, not okay, but better than what they thought. It was the best and worst day of my life. Completely.
And things actually then got better, didn't they?
Yeah, she's just got better and better ever since, leaps and bounds. She's off all the ventilation now. She's just needs to feed and grow.
And so moving from that time, how do you feel about doing skin to skin with her now on a regular basis? How does that make you feel?
Amazing. I can't get enough of her. I cannot pick her up enough, and when I've picked her up I don't want to put her down ever. I can't get enough of her.
And when you're doing it, how do you think that Mila's responding to you?
She's very relaxed. So when she was on ventilation, her saturations were always higher, her oxygen requirement was always lower. Now, still the same, even without any ventilation, her saturation is so much better. She's just relaxed. She's so chilled out. She just sleeps.
She sleeps.
Yeah.
And as a unit, one thing that we're always wanting to make sure we get your feedback. How would you say, in terms of the support that you got from staff looking after Mila, about encouraging you to do skin to skin?
That was brilliant. Absolutely fantastic. They offer screens, if you want full skin to skin contact, and they give you peace and quiet once that they're happy that she's settled. Obviously, especially if she's on ventilation, they'll keep an eye on her. But on the whole, it's encouraged and supported. And like, if my partner was to just whip his top off in the middle of the ward, I don't think anybody would be like, "Oh, what are you doing, Mr. Walker? You can't do that." It's fully encouraged for me and her dad, so it's just brilliant.
That's wonderful. Yeah. And anything you would like to let us know about when we talk to parents about having skin to skin? Perhaps if mummies or dads might be nervous or worried.
I think some parents, so like my partner wouldn't just take his top off. He doesn't have proper skin to skin contact here. And I think it's more that he feels, not embarrassed, that's not the right word. I don't think he feels it would be appropriate, even though it would be, but nobody's made him feel like that. So maybe if the nurses encouraged it more for dads to do that, because I think it is more pushed on mums, not pushed on, that's the wrong word, but presented to mums, offered to them. And I think dads can feel a bit like exposed, whereas mums, once you've given birth, you don't mind. You will whip your top off and just sit there with your baby because you just want that contact with them. It's a different kind of bond, I think, for a mum.
Yeah.
And I think if more dads did it with the top, full skin to skin, that bond would probably be a lot stronger between the child.
Oh, that's wonderful. Thank you so much.
That's okay.
Hi, Emma. Once again, thanks for taking part in this little discussion. I'm hoping that you give us your thoughts on your experience with kangaroo care on our unit, with your lovely Leo, who was born at 27 plus 2 weeks and is now 37 plus 3 corrected and 72 days old.
So when I first found out I was pregnant, it's obviously the scariest thing.
Yeah.
You are now responsible for another life, and then to have him inside moving, they were so special. And then to have a baby at 27 weeks, you're still you're just getting to know them kicking and moving. And then obviously I had my emergency C-section because his heart rate dropped and he needed to come out. So for me that was really difficult, because when he came out I felt alone.
Mm-hmm.
I don't know why I'm getting this.
It's okay. It's okay.
No, it's all right. So for me, it was really important that I needed to see him and feel him.
Yeah.
So, and I felt that was the only thing that I could do at the time for him. And he comforted me, and I felt like I was trying to comfort him through a difficult time. Let me catch my breath.
Take your time.
And because I didn't hold him for a few days, and I was still going through the shock of my C-section, I felt that it made it real to hold him. And it was just so lovely. It was like a bond. It was amazing to feel him, because I'd lost that sensation, obviously, when he was born. And just to hear him breathe on my chest, it was so nice to hear him breathing, and it gave me a bit of reassurance that actually he is going to be okay.
That's wonderful.
So yeah, it's definitely something, because obviously when I had my C-section, he needed resuscitating at the time, and he was intubated. So I only got a few seconds of just holding him and actually seeing him at the side of me. So it was so important for me for my block to wear off so I could come round and actually see him. And even now, at 37 weeks down the line, I'm still having skin to skin, and it makes me happy that I feel like I'm making him happy. And it's the only thing as a mother on a neonatal unit that you feel like I don't know how to put it. I think you are so helpless in the situation that you obviously want to do as much as you can to get them better. And I think Leo has come on leaps and bounds because of my touch, I feel.
You know, I was just going to ask you that. How do you think it's affected Leo?
I think even from a neurological point of view, I think him being able to be on my chest and touching me, I'm thinking he's starting to use his senses, he's smelling me. And the first time he started rooting, I thought it was lovely, because he knew I was his mummy.
Yeah.
And you do worry that if they're taken out early, my first thought was, how will he know that I'm his mum? Like, will he have that connection with me? You do worry that you're not going to have that. So when he started rooting on my chest, that was lovely, because I thought he knows I'm his mum. So yeah, for me it's been extremely important.
That sounds so beautiful. And what would you say your thoughts are on how we as a unit supported you to do skin to skin?
Yeah, I think it's been excellent, because when obviously he was so small and I was so scared of all the machinery, I didn't want to hurt him. That was my main thing. If I hold him, am I going to hurt him? And not knowing what to do with when he was tubed and all his monitoring on. So they really supported me here on the ICU by helping me lift him out and showing me how to hold in his head and how to keep him warm, because that was my other concern, because he couldn't maintain his temperature. But it was nice to know that actually once he'd got a little blanket around him and he was on me, I was also helping him maintain his temperature. So again, I felt like I was doing something for him.
Oh, that's so special. That's really good. I think sometimes maybe there are some artificial barriers, but I'm really pleased to hear that didn't seem to stop you and Leo having that time for skin to skin. So that makes me feel, very accomplished in our unit, able to support you in that.
Yeah, definitely. I mean, it did get easier when he was on CPAP and then high flow. And little by little, every week got a bit easier until I got the confidence to be able to lift him out myself. And just doing that was an amazing feeling, being able to lift him anytime you wanted to put him on your chest. And yeah, the staff have been amazing. They've given me a different chair if I wasn't comfortable, and tried to make me as comfortable as possible so I could enjoy the time with him.
Oh, thank you, Emma. That's wonderful, thanks.
Well, I think Sarah, Becky and Dave, that was fantastic. I think you've covered all of the sort of medical, physiological importance of KMC and shown how it can be done immediately after birth with delivery room cuddles. But I think those interviews are so powerful, aren't they? Just saying what mums feel in terms of bonding and connecting with their babies. But also that last comment about her maintaining a baby's temperature was also really important. Fantastic. Anyway, thank you very much. So in the interest of time, I'm just going to hand over to the Mbale team, to Kathy and Sara and Dr. Derrick, I think, and we'll hand over to them for their case presentation. Then we'll have some time, hopefully, for questions and comments at the end. But in the meantime, please do put some things in the chat, and then we can try and pick those up as we go through the next talk. So thanks very much, Mbale.
Yeah, thanks very much, Kath. I'm just going to turn over and let Derrick start.
All right, thank you very much. My name is Derrick, and I'm a neonatal clinician. I'm going to present with the Sara Talyewoya, the in charge of neonatal unit, General Hospital. Kangaroo care is, then we shall discuss the evidence of immediate kangaroo care, share a case of an extremely low birth weight infant from Mbale General Hospital, cared with immediate kangaroo care. Then we shall also discuss the challenges of implementation of kangaroo care and immediate kangaroo care. So I think Sara can take us through what kangaroo care is.
Thank you very much, Derrick. Thank you, everyone. Good afternoon. My name is Sara. I am a midwife, and I'm in charge of the neonatal unit at Mbale Regional Referral Hospital. And I want to take you through some slides about kangaroo care. And by definition, as you've already heard from the previous presenter, has 3 elements. That is kangaroo care. That includes positioning the baby in the mother's chest, skin to skin. Then also breast milk feeding for better weight gain, and then supportive care while the baby is in kangaroo. And the point to note is that it's not the same as skin to skin care for the term babies immediately after they are born, but it is a package of care for the vulnerable newborns, which is integrated with the other interventions, for example, oxygen, and then CPAP, and then IV fluids together. So I did a video of how to put a baby in kangaroo. This is the
We're just losing your speech a little bit.
Smaller than this. I am saying that I am demonstrating how to tie a baby in kangaroo. This is my mother that we have been taking care of. Her baby, baby looks much bigger now, is 45 days old, but was much smaller than this. So we took a video to demonstrate how to put a baby in kangaroo. And this is what I want us to watch in that video. So we need clothes to tie the baby in kangaroo. So literally, the mother has to be bare-chested, but for purposes of privacy, we decided to cover her breasts. And then we needed a hat, like you see how I put it, then a cloth over the baby, Then this other cloth that I'm taking is one that is going to tie the baby, to fasten the baby on the chest. And all those clothes have to be at the height of the ear so that we don't block the airway. We tie it carefully so that the mother and the baby are both not uncomfortable. So while I'm tying, I also ask the mother how she's feeling. Whether it is too tight, I release it. If it is not tight enough, she will tell me to tighten it. Yeah, so after we have tied kangaroo, the baby in kangaroo, this baby can take in breast milk. As you can see, it has an NG tube. So the mother is also able to feed the baby while the baby is in kangaroo. And then if the baby is still on CPAP, we can also put back the baby on CPAP while they're in kangaroo. So we don't have to forego kangaroo to this CPAP. We do all the things at the same time. Yes. So the benefits of kangaroo care in larger and stable preterm babies, that is those who are above 1,500 grams, data show that compared to the standard care, that is the incubators and the warmers, kangaroo care reduces mortality. It reduces the risk of sepsis, and then in case sepsis occurs, it will be less. Then it also improves weight gain because the mother always remembers to feed the baby. Then there's higher success of establishing breast milk feeding if you're doing kangaroo. Then also it increases the bonding between the mother and the baby, like you've been hearing from the previous slides. It also reduces the risk. It reduces the time the mother stays on the ward. Thank you very much. I will let Derrick take over to do the next slide.
Thank you, Sister Sara. So from the previous present, I think we presented the same study. So this is an evidence to show the impact of kangaroo. And from the Cochrane study, which was published in 2016, so they showed mortality out of the 8 randomized studies. It contributed 40% reduction. Then in hypothermia, it contributed 72%. And in hospital-acquired infection, it contributed a reduction of 65%. Then in exclusive milk feeding at discharge, it was 1.1 times more likely. So the overall was that KMC, kangaroo care, contributed 40% mortality reduction for the newborn who are weighing less than 2,000 grams, clinically stable compared to the incubator care. So the immediate care, it is until recent, most data showed that kangaroo care reduced mortality in stable preterms for those ones who are just less than 2,000 grams. But the majority of the deaths occurred before stabilization. For the local data in Uganda, showed that 2/3 of the preterm deaths occur in the first 24 hours after birth. And the majority of these deaths in the very low weight infants, those ones who are weighing less than 1,500 grams. The self-significance of kangaroo care initiated soon after birth, that's within 2 hours among the very low birth infants before stabilization, was uncertain. Another evidence, I think Dr. Sara has already discussed about this study. She gave us the statistics, which was involving the 3,211 infants with a birth weight of 1 to 1.799, and they randomized to immediate care, and which was the intervention, then the standard care, which was intubate and the radiant warmer until the condition stabilized. Then the primary outcome, they looked at the neonatal period of 28 days, as she explained before, and the 72 hours. So the statistics showed within the hours of duration of skin to skin, which was 16.9 hours for the intervention, then 1.5 hours in the control group. So we can see that the neonatal deaths occurred in the first 28 days. That was 12% for the intervention, then 15.7% in the control group. So we can see a reduction of 25% reduction in neonatal mortality and 23% reduction in the 72 hours mortality. So this is our case for the extremely low birth weight, which we cared in our neonatal unit in Mbale Regional Referral Hospital. So just brief history about the mother who is AAG. She's 24 years old, seral status negative, syphilis negative. She was para 2, no previous preterm infants. The prenatal history, she got spontaneous preterm labor. She only received 1 dose of Dexa from the hospital. She delivered the twins, which were females. The first twin was delivered at 15:10 on 15th of October 2023 and was weighing 740 grams. Then the second twin was delivered at 15:21 on the same day, 15th of October 2023, and was weighing 915 grams. So the oxygen saturation at 15 minutes was 79%. We initiated CPAP at 21% oxygen. Then oxygen saturation at 10 minutes was 86%, and 15 minutes, 90%. So both infants were transferred in the transport trolley to neonatal unit. So in the neonatal unit during the admission, they arrived at 15:45. We took the observations. The heart rate was 150, respiratory rate 45, and was still saturating well. The RBS, random blood sugar, was at 5.0, and it had a temperature of 35.4 with a blood pressure of 39. So we also scored the Downs, which is a tool we use in our unit to assess the severity of respiratory distress, which is similar to Silverman's score. So the baby was transferred to the bubble CPAP at 6 centimeters and 21% of oxygen. We loaded the baby with aminophylline at 6 milligrams per kg. We gave our first line antibiotics of cefotaxime and gentamicin. We don't use the penicillins because most of our cultures are resistant to penicillins. We started the dextrose 5% at 100 mils per kg. Then we initiated kangaroo care with the father within the first hour of age. Then we didn't know the gestation. The mother didn't know the last normal menstrual date. Did not have an early ultrasound scan done. So we used the Ballard score to estimate the gestation. This tool is used to estimate, so it has 2 parameters, the neuromuscular maturity and the physical maturity. So when we scored neuromuscular, we scored 11, then the physical maturity 8, which totaled up to 19. And it corresponds, as you can see, to the gestation, which was 31 weeks of gestation by ballot. So still on day 1, we have a capacity, we did a lung ultrasound, still to assess the respiratory distress. So in the lung scan, we have the scores where we have 0, 1, 2, and 3. So we score in all the 3 areas of the lungs, and 0. If we have only LNs, we score 0. Then if we have LNs and BLNs, that is score of 1. Then if we have coalescent, we have score of 2. Then if we have lung consolidation, give a score of 3. So our baby scored 0 on the lung ultrasound on day 1. Then also we did a cranial ultrasound scan. As you can see, the midline was normal. Then the right sagittal, you can see the posterior horn of the ventricle did not have any bleeding. Then also the hospital area, where you can see the posterior horn and did not have any bleed. So on day 2, so we always take we monitor these babies' vitals 4 hourly. So as we can see, day 2, with the continuous kangaroo care, our temperatures are normalized, our vitals were normal, downs was still at 4. We encouraged more kangaroo and reduced CPAP to 4 centimeters. We encouraged more kangaroo when we assessed the baby at 700 hours, and the downs had reduced to 2. So we continue to tie the baby in kangaroo and reduce the CPAP to 3 centimeters. So we continued monitoring. Our temperatures was still down. We encouraged more kangaroo as the other vitals were normal. General examination, the baby was normal findings. Still, we tied the baby back in kangaroo and we continued our cephalosporin injector and aminophylline. Then we continued with 75% of D5. And also we initiated 2 meals of express breast milk. And also we have lactation support in case the mother had not yet started to produce the express breast milk. So on day 3, as for the continuous kangaroo care, our temperature was at 33.3, as we can see. After kangaroo, it rose up to 36. So we continued every time we could remove, the mother could remove the baby from the chest, the temperature could drop. But after kangaroo assessing, we realized that the temperature could go back to normal ranges. So on ward round, when you assess the baby, our CPAP was at 3 centimeters still. We will continue with the antibiotics. Our temperature still, it had come down. All the findings were normal. And we had to put back the baby in kangaroo. So to recheck, the temperature had gone back to 36.5. And we continued with antibiotics. We increased our feeds for the baby in NG tube and also reduced the amount of fluids. So we repeated the outer lung, the lung scan on day 3, and we scored 3. So the distress had a little bit gone up. Then on day 4, still now we continued the 4-hour monitoring, and our temperature, I think we can see when before and after kangaroo, they were all in normal ranges. So on ward round, we are still on CPAP, we are still on our antibiotics. We're on our express breast milk. Our temperature was normal, 36.7. Our weight had dropped. All findings were normal. and we had to tie the baby back in kangaroo to maintain the normal temperature. So also we had to increase the express breast milk on day 4 to 6 to our in the NG tube. So after 72 hours, we always do a screening echo for these preterm babies. And from there, as we can see, we had the left right shunt of the PDA. Also, we found the dilatation of the left atria and the absent end-diastolic flow. So it was a significant rate for paracetamol for our protocol. And we weighed the baby, was weighing 805 grams. We stopped the IV fluids because of the PDA. Then we continued with cefotaxime and Genta. We continued kangaroo mother care. The temperature had stabilized. It was at 36 even after kangaroo. It went to 37.3. We increased the express breast milk because the mother's milk had increased. Then we stopped antibiotics at day 7. We just continued with amnoflin and the multivitamin drops. So the baby's weight had increased on day 15 back to birth weight. So the baby was weighing 920 grams. And you can see we are still on CPAP, but we were gaining and our temperature also normalized. So this investigation we did, so by the time we repeated our echo, the PDA had closed, and also on day 7 of the coronal scan, it was normal and we didn't find any ventricular hemorrhages. So this baby got some significant events. So on day 17, the baby developed temperature stability at night, despite kangaroo. Then on ward round, we found the baby was tachypneic, was having a respiratory rate of 95, down score had increased from 0 to 3. It had started desaturating, was saturating between 86 and 91 on CPAP. That was the weight of that day, which was 1,050 grams. Then we did the malaria screening. It was negative, so we decided to start the baby back on cefotaxime and amikacin, which is our second line of antibiotic. So the baby responded within the 72 hours. On day 28, we screened for anemia, and the HB was 9.1, and we had to do a blood transfusion for the baby. So another event occurred on day 32. The baby developed septic shock and severe respiratory distress with apneas. The temperatures went up to 39.3. Though the baby was still gaining, the down score went to 7. So we put the baby on bubble CPAP. We increased to 10 centimeters and 70% of oxygen. We stopped feeds. We continued with amnoflin. We started the cefotaxime and amikacin, but there was poor response, so we had to change to meropenem. So on day 41, the baby was back on full feeds. We reduced the bubble CPAP to 3 centimeters and 34% of oxygen. By day 45, which is today, because the baby is still on ward, we stopped the CPAP and put the baby back just on oxygen at 0.5 liters, and it is establishing feeds. So the baby is still on ward, and that was the care we have given so far as they are waiting for discharge. So I think I can hand over back to Sister Sara to take us in the immediate kangaroo care in reality.
Thank you so much, Derrick. Sorry. So the reality in Mbale about our experience doing kangaroo is that in 2014, when we were starting the neonatal unit, we had some challenges starting kangaroo care. And those challenges were that people feared to put their babies in kangaroo because It was a new concept. People didn't know about it. Then also there was a fear of of handling new babies, especially the person who would be requested to do kangaroo, maybe a mother, grandfather, or whatever. They feared to handle those small babies in their chests. Then also most of the health workers were not aware about the practice. So that we needed to do some trainings. And there was no access to bathing for mothers because many of them came from the lower health facilities and they were not clean enough to do kangaroo. They needed to first bathe, but we had no such facilities. But that has changed since. And then the misconception that we needed space to do kangaroo, which has changed now. We know that right now we can do kangaroo even with a small space, wherever you are, you can do the kangaroo. So Mother AAG, when we asked her about her challenges, and this is what she had to say. She said, it's so tiresome when I am alone and I am the only person placing the baby in kangaroo the whole day. Then also she said it requires me to sit for a very long period of time whenever I'm placing my baby in kangaroo care, which makes my legs swell. She also said that if I'm the only caretaker and I fall sick, then there will be no one to place the baby in kangaroo. And also she also talked about many times my time for sleeping reduces. So most of the time I sleep on the ward with my baby in kangaroo. So those are some of the challenges which Mother AAG has had about kangaroo. Yeah. So, and her benefits, she says, it helped to bring our family together since both of us, father and mother, were able to share the responsibility of placing the babies in kangaroo. Then she also talks about kangaroo helped me to closely monitor my small baby, especially when they are stopping to breathe. As the mother, I feel the chest movements and the heartbeat when the baby is in kangaroo. Also, I realized that by putting my baby in kangaroo, it grows faster. Each day the weight increases. I feel comfortable to feed my baby when it's placed in my chest, other than just lying down in the cot because milk can come back and choke the baby while lying in the cot. You know, she also said placing the baby in kangaroo keeps it warm, and each time the temperature is taken, it is always in the normal range. She also said when a baby is placed in kangaroo, baby's breathing rate and heartbeat connects to that of the mother and makes it breathe well. So while we were doing kangaroo, we have also had challenges as health workers, but in the delivery unit, our biggest challenge is that in doing kangaroo, many times babies need to be resuscitated, so you cannot put them in kangaroo care. Then those needing CPAP, it is also very hard to do for them immediate kangaroo care. Then when you need to cannulate and give some treatments immediately, you cannot start with kangaroo care. Also, the babies needing to be transferred to the neonatal unit are not able to be done kangaroo immediately because they will be in transit the time they will have needed kangaroo. In the neonatal unit, some of the challenges that we have is that while you need to do kangaroo, sometimes it's not possible because babies need to be done of the observation like weight and temperatures and whatnot. So it is not very possible for us to start immediate kangaroo care. Then there is sometimes you have no attendant. If the mothers come alone with preterm labor, they push out the baby and then they remain in the delivery unit. So you just have the baby alone in the neonatal unit with no one to do kangaroo. Then early on, there is limited understanding. When the person has just come to the unit and you ask them to do kangaroo, they will not see the importance of doing kangaroo care until after some days. That's when they realize that it is important. Then also the other challenge is that we all know that we lose more heat on the head, through the head, and you need to cover the heads, but usually we depend on donations to get those hats. So the times when we don't have the donations, we can't cover the baby's heads, so it is very hard to keep them warm. And the bed sheets, or the sheets that you need to use for doing kangaroo in the unit, when the babies have just been sent to the unit, usually preterm labor is like an emergency. People are not ready. So by the time they reach the neonatal unit, they don't even have those sheets. So you can hardly do kangaroo immediately. Then also Pampers, we always ask them to buy, but in an event where a mother is unable to buy Pampers, so you put them in kangaroo and then they make themselves wet, and it makes it a challenge for them to get warm. And then when they're having frequent apneas, it is a big challenge. You can't keep them in kangaroo. You put them in kangaroo 1 minute, it has stopped breathing, you remove, so it becomes very hard. Yeah. So the point is that we need to start small and with whatever we have. We were thinking that we needed a big room to do kangaroo, but here our mothers comfortably doing kangaroo in a small place, and they're accessing all the services. They have the CPAP, IV fluids going on. So I think with what we have, we can be able to do immediate kangaroo care. So we did some trainings. In the picture on, is that left? There is our junior doctor teaching about kangaroo care in the lower health facilities to those health workers in the lower health facilities. And after the training, this other picture shows us how a midwife was able to put the baby in kangaroo and then send them to the regional referral. And they reached very well, and their temperature was good, they were breathing better. So we thought this was a good thing. Thank you very much for listening. We want to say thank you to our mothers, fathers, the staff of the unit, and most especially the management of the hospital, born at the age, for their support. Thank you very much.
Thanks very much, Sara and Derrick. That was absolutely amazing. It always just brings it home to me that it's such a simple intervention. We should be doing it all the time, and actually we don't, but it makes such a massive benefit to our babies and to our mums. And I think the quotes that you put on there, Sara, from your mum about the benefits were the same as Sarah's video from Yorkshire, exactly the same benefits. It was really powerful. So there's just some comments in the chat, which I'll just bring up, and then obviously any other questions. But basically lots of thank yous about an amazing presentation to everybody. And then Chloe just was wondering if there was a way of us from in the UK getting some donations to you in terms of hats and sheets, that we would be very willing to support that. So we need to have a think about that from our LMNS point of view. Just from what you said, Sarah, is quite difficult, in fact, if the mothers haven't got hats or sheets to do KMC. So we need to look at that from a UK point of view about supporting you. And then Nelson, you've put in a comment about social support. I don't know whether you want to comment anything, Nelson. I can see you're on the call.
Yes, thank you very much. And thank you all the team that have presented today. You know, I was just commenting on the presentation, especially the survey by Mbale team. you know, the interview of this mother, especially when she raises concerns of, you know, getting fatigued, you know, looking after the baby alone, sitting for so long, you know, sometimes developing swelling of their feet. And so it really, it sends a signal that somehow she's actually left alone without any social support. And I'm wondering where is the father of this baby, where the other, you know, close relatives could support her in the facility. So I think it's an area that we probably need to explore if we want KMC to succeed. But in addition, I also think, you know, KMC seems to, you know, bias people's feelings, especially the fathers. That is a sole responsibility of the mothers. And I have a feeling that if we probably refer to as skin to skin, then it's a little universal and everyone will be able to take this responsibility. Thank you.
Thanks very much, Nelson. Kathy's replied, and I think completely right. Actually, people are moving to kangaroo care. Go for it, Kathy.
Yeah. I was going to say, Nelson, I totally agree. And actually, we don't call it kangaroo mother care at all here in Mbale. We just call it kangaroo care, or actually kangaroo for short. So I think I feel quite strongly, and I think you do too. Kangaroo mother care is just not the term to call it. This mother, actually, the father was around and for about the first 2 weeks and was fantastic. He did most of the kangaroo whilst mummy was recovering. But it's hard. We say, oh yeah, you just tie the baby on the chest and get on with it. But I don't know, I suspect very few of us on this call have actually tried to do kangaroo. It's exhausting, it's tiring, the baby wheezes on you, it poos on you. It's not a fun thing to do. So I totally agree. We need more support for these mothers to make it more comfortable. But until we have that social support, we need to implement it as best we can with what we have so that these babies survive. But Nelson, you leave here today and be one of our advocates of calling it kangaroo care rather than kangaroo mother care. And I think I totally agree. It will become much more inclusive for everybody involved.
Thanks, Kathy. And I have to say, I was in the UK, we've seen, to start off with, it was always the mothers, and now it's very common for all the for the fathers to be involved. And I think you're right; it should be kangaroo care for the whole family, shouldn't it, to get them involved? And in fact, in the Karolinska in Sweden, they have a maternal bed, and the family literally move in to where the baby's room, basically, until the baby's discharged, and so the whole family can be involved in looking after the baby and having the baby in kangaroo care. Any other comments or questions? I can't see anything else in the chat apart from amazing thank yous to everybody in terms of the presentation. I think we've really had a really good overview about all of the benefits from a physiological point of view, from the baby point of view, and from the mother point of view. And really, I think the video that Sara, you showed us, you know, shows actually how easy it is. And what I really liked from your presentation, Derrick, was that actually you showed some really high-tech neonatal care in terms of lung ultrasound, cranial ultrasound, echo, managing a PDA, but all in the background you had the really essential care of kangaroo care going on, and that was so lovely to see in your presentation. So thank you. Anybody else got any comments or questions? Just shout out, raise your hand, or put it in the chat. But I think, I mean, we've had 7 grand rounds so far, and I think this has been a really good one. It's shown a really good MDT approach. I think we in the UK have learned lots from you in Uganda, and hopefully vice versa. It's been really, really good. So we're just going to end that now, unless anyone's got any final comments. Kathy, any final comments?
No, thanks, Kath. Just a huge appreciation for everyone joining. It was really interesting to hear how kangaroo and skin to skin is implemented in the delivery room in the UK. And I think our team definitely will try and take something away from that, try and bring a little bit of skin to skin time into the delivery room. But we do try and get it within the first couple of hours if we're able to. But it's just been really great. Nurses, doctors, clinicians, midwives, I think we've had a really great display of the MDT team, like you've said, and so much appreciation for everyone to joining. Wishing everyone a happy Christmas and New Year, and we look forward to seeing everybody in the next session in 2024.
Yeah, I agree with Kathy. It's been a really, really good session, so thank you very much.